Hello again, everybody. Again, I'm David Rodriquez-Buritica. I'm one of the medical geneticists at the medical center. And I'm here with Blair Stevens, who is a prenatal genetic counselor. And we typically get involved as geneticists and as genetic counselors in the early diagnosis of patients with Turner syndrome. Myself in the postnatal, once the babies are born, we're called to assess the babies where there is suspicion of the diagnosis of Turner syndrome or later on in life. And as we're going to see, it's also a common scenario. And Blair is involved during the prenatal that recently, due to the use of NIPT, has become a common scenario for the diagnosis of Turner syndrome. So we're going to be reviewing some key points today. As I discussed this morning, again, after almost 90 years of, or more than 90 years of the initial descriptions of girls with Turner syndrome by Dr. Ulrich and then the case series by Dr. Turner, we're still learning about Turner syndrome. And I don't think that's ever going to stop. As we get new tools and as we get to know exactly what happened in terms of the pathophysiology of it, we learn more and more and more. And these are just some of the milestones. And there was a patient earlier that asked me about this slide. Okay. So in terms of the diagnosis, around 1960, chromosomes became available, and then we knew what causes Turner syndrome. Then in the 80s, FISH became available, and it was easier to actually assess mosaicism. That is a common characteristic seen in Turner syndrome. And the latest development is the development of a technique that is called a microarray, which is like many FISH probes that attach to pairs of the chromosomes, and that give us information of if there is a missing pair of the X chromosome or the Y chromosome, which part is missing or extra, and help us sometimes knowing exactly what is going on with the patient. Again, I want to touch about this because I think it's important when we're talking about Turner syndrome, and this is a point where the guidelines are very specific. We're talking about girls, and we're talking that there are specific changes in the chromosomes, and there are specific or a list of medical issues associated with that. And that's when we, as clinicians, eventually diagnose that somebody has Turner syndrome. However, the changes in the chromosomes are not exclusive to Turner syndrome patients. We know that there is a large group of patients that also have chromosomal conditions, and there is a large group also that have chromosomal conditions associated with the sex chromosomes. And it's important to differentiate based on the clinical characteristics and the type of changes on those chromosomes, if that person has a Turner syndrome or not, or has any other of the conditions that are related with the sex chromosomes, and if there is an issue associated with the sexual differentiation of that person. And I'm going to let Blair talk about the prenatal aspect of it.
Dr. Rodriguez. So thank you all to the organizers and to all of you for your attention. I think it's amazing how you guys are here and advocating for a loved one or for your own health. Just curious, show of hands, who here has seen a genetic counselor or had a genetic counseling visit? Oh, that's so impressive. Excellent. Many people have no idea what a genetic counselor is. I've spent most of my adult life explaining what that is. Many of you guys know that. And as Dr. Rodriguez said, I'm a prenatal genetic counselor. So oftentimes I help families adjust to a diagnosis that's often unexpected. For those who have had a genetic counseling visit, or many of you I'm sure have met with the geneticist, you'll probably recognize pictures like this one. We often start our sessions with a description of chromosomes. So in case you don't recall, or in case you haven't had this spiel, we think of our chromosomes as the genetic information or genetic instructions that tell our bodies how we typically develop. And everyone in this, room has chromosomes, and we all have lots of differences that make us unique and wonderful. But sometimes chromosome differences can also cause health problems or different conditions with our development. And so specifically today we're focused on the sex chromosomes. Chromosomes number 1 through 22 are the same in everybody, but typically females have 2 X chromosomes and males have 1 X and 1 Y, but we do know that a person with 1 X chromosome is also going to develop as a female, but with just some unique differences with some medical and developmental things. And so how do we get these chromosomes, and how does Turner syndrome occur? And so first of all, it occurs by chance. There's nothing you can do to cause Turner syndrome. There's nothing you can do to prevent Turner syndrome. It can literally happen to any pregnancy. It's not associated with maternal age. I know other chromosome conditions get that rap about Down syndrome being more common when the older you get. Turner syndrome is not the case for that. It's just a random event that happens. And it can happen with either the sperm or the egg's development, or it can even happen after conception. So it's just kind of a random event that occurs. And if you remember back to high school, you might remember terms like mitosis and meiosis. I'm just going to do a very brief review. I know some people have trauma from those terms. I'm not trying to bring that trauma back, but hopefully you find it interesting where you can see like where did this come from and how did it occur. So I don't think there's a pointer, but if you look on this slide, it just shows an example of 2 chromosomes. Of course, we have 46, but in this picture, you'll see that there's a cell division because we have 46 chromosomes typically, but we usually pass on 23 to our children. And so there should be a set of divisions that occur. So what do we think happens with Turner syndrome? There's kind of 2 main ways that Turner syndrome can occur. So let's just pretend that these chromosomes represent like chromosome 10 and chromosome X. On the left-hand side, you'll see anaphase lag, and that essentially is like one of the X chromosomes isn't quite, making it over to the side that they're supposed to. So in the middle of that screen, you'll see that blue chromosome kind of lagging behind. If that's the X chromosome and it doesn't make it over to its side that it's supposed to, that cell divides and it kind of gets left behind. And so the subsequent row, you'll see that little purple chromosome is by itself. So that would be an egg or a sperm with a missing sex chromosome. Whereas the other side, you can see that there's typically the 2 chromosomes there. Alternatively, you can have what's called non-disjunction. Our chromosomes kind of become friends, and sometimes they don't want to separate and go to their side. And so it's kind of like when you have kids and you say, go to your rooms, and they're like, no, I want to go to their room. It's like, no, you need to go to your own room. Well, sometimes they don't listen. And so you can see on the bottom of the non-disjunction side, there's some chromosomes that have 3 copies and one that has 1. So that would be like a missing X and 1 copy and then an extra X. So some people have what we call mosaic Turner syndrome, which we'll get to in a second, but you might know someone that has a missing sex chromosome in some of their cells and 3 X chromosomes in another one. It's probably due to non-disjunction. And usually, but definitely not all of the time, this chromosome division issue will occur in the egg or in the sperm right before conception. But there's also exceptions where I mentioned mosaicism. So mosaicism essentially just means that you have more than one cell line in your body. Some of the cells in your body might have a Turner syndrome complement, and other cells in your body might have the typical XX or the XXX that I just mentioned. And so it's just kind of a mosaic mix of cell lines. And so sometimes you start out as a 46XX conception, and then sometime after the egg and the sperm meet, there can be an anaphase lag or a non-disjunction event that causes the Turner cell line. And you'll hear more about the variability of Turner syndrome. Part of that variability is probably because there's a lot of mosaicism going on with people with Turner syndrome. And depending on what type of testing that you went through, you might have got a test result that says you are a mosaic. And so it just depends on kind of what test you get and what tissue your Turner cell line is in, whether you pick it up. And we always say that mosaicism kind of complicates any genetic test because we can never be 100% certain about anyone's diagnosis because we can't test every cell in your body. So postnatally, we usually rely on blood, but prenatally, there's a lot of different types of tests that can identify various cell types. So if anyone in this room has Turner syndrome, I want you to just give yourself a pat on the back because you survived. Congratulations. Yeah, that I hope is a testament of your resilience. If you're ever struggling with any aspect of your condition, I hope that you look back and think, you know what, I survived the pregnancy, so if I can get through that, I can get through anything. So unfortunately, not all people with Turner syndrome or not all individuals with Turner syndrome do survive. You can see the statistics here. It's not an uncommon diagnosis when we're talking about early conceptions. So 1 in about 1,500 12-week pregnancies has Turner syndrome, but you can see the numbers kind of dwindling to 1 in 3,000, 1 in 4,000, and unfortunately that's because many of these pregnancies result in either miscarriage or stillbirth later on in pregnancy. We detect it in about 10 to 20% of miscarriages, but unfortunately, if anyone's had a miscarriage, like not all the time do we test those samples, and so oftentimes we don't know what the cause of miscarriage is. And then, once again, mosaicism makes things challenging. So if not the entire pregnancy was diagnosed with Turner syndrome, we might miss the cell line that has it when we do a test and essentially give parents a false negative. So prior to 2011, 2012, we really had no way of looking for Turner syndrome with a blood test. We would just rely on invasive testing and ultrasound to screen for it. And most people aren't super excited about getting an invasive procedure when they're pregnant. So most of the time we just didn't detect Turner syndrome without like an ultrasound bringing it up. But as of 2012, we really started doing more blood testing. And so we're seeing a lot more cases of Turner syndrome pop up in pregnancy that we didn't before. Mother's blood, yeah. And we'll talk more about it, but right, when you were pregnant, if you were pregnant 30 years ago, it's kind of crazy to think that they can find some of these genetic conditions in a baby by just looking at mom's blood, but technology has come a long, long way, especially when you think this is the only way that we used to be able to find it. So diagnostic testing is just simply a test that's more of a yes or no. And so in the first trimester of pregnancy, they can do something kind of similar to a pap smear procedure where they take a piece of the placenta and they can test the placenta for chromosome conditions. Or in the second trimester of pregnancy, they can go through mom's tummy and get a sample of amniotic fluid that baby floats in. Most of the time, these procedures are safe, but there is a chance of miscarriage when you go invasive into a pregnancy. So understandably, many parents are a little nervous or anxious about doing anything invasive in order to get this diagnostic information and would much rather go for something non-invasive, such as blood work or ultrasound. And all of these tests are optional, by the way. Some families find value in knowing information ahead of time and being more prepared. Other families think that it's not information that's necessary to them before delivery, and they would rather wait and find out information after their baby is born. So by no means does any obstetrician require anyone to go through testing. It's completely up to the family and their values. So here is a picture of the blood test that I was mentioning. Most people call it NIPT, which is non-invasive prenatal testing, or cell-free DNA screening. What's cool about pregnancy is when you're pregnant, baby's placenta sheds genetic information from the outer layer of the placenta, and so it gets into mom's bloodstream. So if anyone's pregnant, they have about 10% of their DNA in their bloodstream is from the pregnancy, and 90% is usually their own DNA. Because of mosaicism, it is certainly not a perfect test. Sometimes your placenta has Turner syndrome and your baby doesn't. Sometimes your baby has Turner syndrome and your placenta doesn't. And sometimes there's just a mix all over the place. And so we say that there's probably an 80 to 90% detection rate, and there can be false positives. So it's not diagnostic, but it's a non-invasive way of looking for Turner syndrome if that information is valuable to you. Oftentimes people will call this the gender test because they just want to know the sex of their baby, which there's nothing wrong with wanting to find out the sex of their baby, but sometimes they don't realize that we're looking for other things like Down syndrome or Turner syndrome. So some people aren't sure what they're signing up for when they get this test, and so the results being anything but typical can be really unexpected. But it at least gives people that would like that information some time to understand the diagnosis and get an earlier diagnosis, because sometimes if we get earlier diagnoses with Turner syndrome, we can be better prepared to take care of babies. And then, once again, ultrasound findings are not uncommon. Statistics like these exist in publications, but sometimes those publications are skewed because we're looking at pregnancies that have been diagnosed with Turner syndrome, and so we might not get some of those cases that are mosaic individuals. So some ultrasound findings that we might see when you go in and get an ultrasound in pregnancy is what's called a cystic hygroma, or an increased nuchal translucency. These are things related to mostly the back of the neck. Our lymphatic system kind of runs back here, and fluid can accumulate at just a little bit of extra fluid in the increased nuchal translucency, which is seen in the picture on the left. And so this little space, I don't think there's a pointer, but the little extra fluid back here is just a little bit of extra. It usually resolves, but it can be the initial signs as early as 10, 11, 12 weeks. And then in the picture on the right, it is a little bit farther along in pregnancy. That line, the yellow line that you see going across, is going across the baby's head. So on this side is the baby's forehead, and on this side is the back of the head. That black circle behind the skull, that's just a big fluid-filled sac. I kind of think of it as like an airplane pillow that you take to the airplane, kind of that behind your head, but it's filled with fluid. If that resolves, there's usually no consequence or major concern, but sometimes that fluid buildup doesn't just persist in the back of the neck area. Sometimes fluid can start building around the lungs, around the heart, in the tummy, or just generally throughout the baby's body, and that's one of the leading concerns that babies might not survive the pregnancy. So those are things that we look for very closely. And then we've already talked about the heart, but doing a good close look at the heart's really important. Where things like hypoplastic left heart syndrome are almost always diagnosed prenatally and almost always recognized before a baby goes home, things like coarctation of the aorta can easily be missed on a prenatal ultrasound, and those can have major consequences if those babies go home and we don't know that they have a coarctation. So typically, during pregnancy, you get a 20-week anatomy scan. They look at baby from head to toe, including the heart. If everything looks good, you may or may not get another ultrasound in your third trimester. If you do, they're probably just looking at baby's growth, fluid levels, nothing super specific. So if we know that a pregnancy is at increased chance for Turner's, or if we have a diagnosis, we're going to be looking at that aortic arch really closely, including in the third trimester when sometimes it presents more commonly. And so once again, mosaicism makes all of this challenging. Many of you in this room might not have had any prenatal ultrasound findings like the ones I described, and that could be because of mosaicism. It could just be because Turner syndrome is a super variable condition. Not one person has the same exact features as someone else, and mosaicism is one of the reasons. And once again, mosaicism is one of the reasons why none of our genetic testing is 100%, so we never claim 100% with anything, essentially. So I just wanted to present a quick case example. This is a picture of a baby at probably 11, 12 weeks, and that little yellow measurement is the nuchal translucency, which is that fluid space behind the neck. That's a typical measurement. It's not increased, so everything on this woman's first trimester ultrasound looked very reassuring. But then she had this blood test, NIPT, and it said that there was female sex predicted, but in the fine print that I'm sure no one can read on this screen, it says there's something atypical suspected in mom's chromosomes. And so we decided baby was probably not something that we needed to focus on, but we started focusing on mom and her chromosomes. But as we know, she's pregnant, so Turner syndrome certainly wasn't something that was on our radar very much. And it turns out she was a mosaic Turner syndrome individual. So she had 46 XX cells and 45 X cells in her blood. And she's pregnant, she was healthy, she really didn't have any medical conditions that we were worried about, so some might argue this is information that wasn't super helpful, and why did we go through all of this work to get her a diagnosis? And part of it is, you heard about some of the heart stuff that's involved, and if someone is pregnant, that does put extra strain on someone's heart and during labor and such. And so there is a risk of death because of aortic dissection, and so if we never looked at this person's heart, because she had no symptoms or no diagnosis, we might not know that she has a dilated aorta. So we recommended she get her heart checked out before she deliver her baby, just to be on the safe side. So early diagnosis can be key for a number of reasons. Does it need to be prenatal? Not necessarily. There's a lot of things that don't change in pregnancy. If we know that a pregnancy has Turner syndrome, would it be nice to know the moment that baby is born so that we can make sure we don't send a baby with a coarctation home from the hospital? Absolutely. And so if information is valuable to someone before that day, then we're happy to do prenatal counseling and prenatal testing. But I think early diagnosis and making sure that we manage the medical aspects of Turner syndrome is our main priority. So I think that's all I have. And I will pass it back over to Dr. Rodriguez.
Thank you, Blair. Okay, so now I'm going to talk about the postnatal aspect of Turner syndrome. So what happens after the patients are born? And as we all know, what we want to see is those genetic changes on the chromosomes associated with the physical findings. And this is just a brief list of the most common physical findings that we find on girls with Turner syndrome. Based on what Blair knows about the variability of the condition, it's difficult to find that two girls with Turner syndrome have the same physical findings. It's extremely variable. And there are not necessarily physical findings that everybody with Turner syndrome for sure has. So it is very important to be aware of those physical findings from the diagnostic point of view, because once we receive the information on the chromosomes, we need to make sure that it's occurring on somebody that does have Turner syndrome or has the clinical findings, because the same chromosomes eventually could be seen in other individuals. And this is one of the aspects that I touched base this morning during the guidelines. I think we were planning on audience response for this. I don't know if there is a way to capture the audience response at this time. So if you want to go ahead and answer the question. So which one do you think that is the chromosome that is missing? All right. Go ahead. Okay, any other answers? Three, so X and Y. Anybody else wants to venture? Three, so X and Y. Anybody else? 2X. Okay, can we show it again? Oh, that's me. Go. Okay, so again, the correct answer is actually 3. Again, this is an aspect that it causes confusion eventually. I will tell you that in the medical literature, there is a lot of confusion about it. It's often said that Turner syndrome is the absence of one of the X chromosomes on a girl, but the reality is it could be an X or a Y. It's difficult to say, especially when we're facing the situation of a 45X, we don't know which one is the missing chromosome. And that is the reality. Now, we were facing a case, for instance, of a girl that is mosaic, where we know that there is a 45X and then a 46XY cell type is easier to solve that answer. Other possibilities, for instance, is that there is different combinations of cell lines. One is a 45X, the other one is a 46XX. We know that the original chromosome that is missing is the X, but when it's a 45X, there is not necessarily a way to know unless we do additional testing or unless there are other physical findings that suggest that there was a Y chromosome present at some point. The other aspect that you're going to tell me is, okay, so girls typically have 2 X chromosomes. So why does it happen that girls with just 1 chromosome have so many symptoms? And one interesting aspect that happened in biology is that one of those X chromosomes eventually turns off, and in normal females. So why they don't have any symptoms associated with Turner syndrome in general? And it's a very, very interesting question, and that explains sometimes why there is such a degree of mosaicism. Is because even though we are seeing sometimes some girls with Turner syndrome, 2 cell lines, one cell line that has an structurally different chromosome X and another cell line that has 46X and X, one of those chromosomes are going to be turned off. And if it's a structurally unusual chromosome, chances are that that chromosome is going to be turned off. And depending upon the proportion of cells that have the chromosome that is structurally abnormal being turned off, then we're going to have more symptoms or not. And that's another aspect that explains the variability of the condition and the mosaicism that we actually see in Turner syndrome. Another important aspect here that will help us differentiate all this controversy that eventually exists regarding the chromosomes and why the chromosomes don't necessarily make your diagnosis is the developmental process that happens on an individual that is originally a 46XY embryo. During the initial 6 weeks of life, boys or girls, we do look the same in utero. And if we have a Y chromosome and we have a specific gene in that Y chromosome, that specific gene, what it's going to do around week 6 to 8 is make the gonads, which is the original tissue that produces the testicles or the ovaries, is make the gonads commit and transform into what it looks like a testicle. If that Y chromosome is lost before week 6, that process doesn't happen, and that's why we can see 45X where there's missing Y chromosome, and those individuals look like they have Turner syndrome. But if the process of losing that Y chromosome occurs later, more later when already there is presence of some testicular differentiation, some elements on the testicles, then that individual is going to have is going to look more like a male. And the reason is because the presence of this Y chromosome and the change of the gonads is more instead of looking more like an ovary, looking more like a testicle, though that tissue is going to produce a hormone that is called anti-Mullerian hormone, and that hormone is going to make the uterus disappear in a 46XY individual. If it's early, it could be that then the next step, which is the production of other hormones that have to do with the changes of the external genitalia, actually is not going to happen. So that individual is going to look internally is not going to have a uterus, but externally is going to look like a female. So this is all sort of a developmental process that eventually explains some of the aspects that we see associated with changes in the chromosomes, and explain particularly a group of individuals that could be diagnosed with Turner syndrome. Well, eventually there are changes on the uterus. But again, this point is to tell you, just to bring the main idea, that if that Y chromosome is lost before week 6 or 8 after conception, then that baby is going to look like a girl, have a uterus, and eventually is going to be diagnosed with Turner syndrome. Again, Blair touched based on this, and it's very important. This is a genetic condition, but it's not inherited. There is a lot of lack of information exactly on knowing why babies with Turner syndrome are conceived. Does the loss of the second sex chromosome happen very, very early, or does it happen a little bit later and explain the presence of patients with mosaicism? That is something that we don't necessarily know. How much of that eventually explains what we see on the patients is something that we don't know. But as Blair mentioned, most of the girls with Turner syndrome actually don't make it to the end of the pregnancy, and just a small proportion of them make it at the end of the pregnancy. Most of the girls that we recognize in the newborn period, if an IPT hasn't been done during the pregnancy, is girls who have a blood karyotype, blood chromosomes of 45X. And for those girls, the physical findings are usually evident. The coarctation of the aorta, the remainings of the cystic hygroma, which is the presence of a broad neck with a low posterior hairline, eventually the puffy feet. Those are clinical findings that suggest that we're dealing with a girl with Turner syndrome. Whereas those girls who have mosaicism, their clinical presentation is milder, is more subtle, so the diagnosis is more difficult, and most of the time is not done during the neonatal period. It's done eventually when they're have slow growth, or when they don't enter into puberty. And again, according to what Blair mentioned, there is a small proportion of patients with Turner syndrome that do go into puberty on their own, eventually could get pregnant, and that's when we diagnose them. It turns out that this loss of the second sex chromosome is not a very well-known process. And we know now that as time passed by, our cells lost that second chromosome. And it's actually a phenomenon that lately we have more information and explain why eventually we see females that when we look at the chromosomes in the blood, we see that there is a large proportion of cells that are actually 45X, but they don't have any of the typical findings of Turner syndrome. This is usually diagnosed because they have other medical problems, particularly it could be cardiovascular problems. And the same process happened for the males. We now know that as we age, then it's not unusual that a group of our cells lost the Y chromosome, and if that happens, that is linked with some other medical conditions. Cardiovascular condition is one of them, but also Alzheimer's disease, as there are other conditions. So again, this process of the loss chromosome, of the sex chromosome, is nobody's fault. It looks like it's a developmental process that on a girl with Turner syndrome happened very early in life, but it's something that it could happen later in life. And this becomes important because one of the group of patients that are excluded from the diagnosis of Turner syndrome are females that are older than 50 years of age that have a very small proportion of cells that are 45X if they don't have any physical findings of the common physical findings that we see associated with Turner syndrome. I want to insist on this aspect because it's very important, the presence of mosaicism. Most of the times the diagnosis is made on blood chromosomes, but again, the proportion of cells throughout the body may be different. We don't necessarily test other tissues. Eventually, we could test many, many tissues, but we don't necessarily do it unless there is a specific question that we want to answer. But one of the main ideas in Turner syndrome is that there is the likelihood that there has to be some degree of mosaicism for survival. So if we were to look on any girl with Turner syndrome on all the cells of the body, which is basically impossible, we would probably identify different population of cells with different constitution of chromosomes. And this is the other aspect. The sex chromosomes could be different. They could have different shapes. And eventually, the shapes of these chromosomes and the amount of genetic material will give us a hint of what to look for on those patients. The first one on your left is a chromosome that, well, again, the X chromosome is conformed of two arms, a short arm that is called the P arm, and a long arm that is called the Q arm, and there could be missing parts on any of those segments of the chromosome. The first one is one chromosome that has a missing part of the tip of the short arm, and we know that there is a very important gene that Dr. Rivera mentioned earlier today that has to do with growth, that's called the SHOX gene. So that's the reason why we see short stature on girls with Turner syndrome when they're missing this part of the chromosome. The chromosomes could be what we call isochromosomes, and they could be composed of two short arms or composed of two long arms. And what we know, for instance, is that since the SHOX gene is located in the tip of the short arm, if there are two copies of the short arm, then chances are that those girls don't have a lot of problems with short stature, or not as much as girls who have other constitution of chromosomes. They tend to be a little bit taller, and again, it could be possible that there are girls with Turner syndrome that are actually tall because of that particular type of chromosomes. When there is an isochromosome that has two long arms, it's called an isochromosome Q, and those girls tend to have less problems in terms of cardiovascular disease. When the tips of both arms are missing, and then the chromosome is actually reattached from the two tips and it forms a ring chromosome, that's what we call a ring chromosome. And chances are that that particular ring chromosome is an X chromosome, and typically that has been associated with increased risk of intellectual disability. But again, not everybody that has a ring chromosome has intellectual disability, possibly because these structurally unusual chromosomes have a different proportions throughout the body and is not in the central nervous system if the person doesn't have intellectual disability. And then another unusual shape of those chromosomes is what is called an isodiacentric. That is a very unstable chromosome that has two centers and then a center of genetic material in the center. I'm going to touch base again of, okay, so we sort of have an idea of what are the chromosomes of the person with Turner syndrome. What information do we know about it? Unfortunately, we don't have all that information, and there is no way to predict all the medical problems or the medical issues that we see on a person with Turner syndrome just based on the blood chromosomes. But we have an idea of things to look for. I mentioned SHOX gene on the tip of the X chromosome. The same gene is also on the tip of the Y chromosome, and it explains why girls who have a Y chromosome material that is structurally unusual, but they are missing that SHOX tip, that's why they also have short stature. There are a lot of genes in the long arm, in the Q arm, that are very important for development of the heart and very important for the development and maintenance of the function of the ovaries. So whenever there are missing parts, large sections of the long arm, the Q arm missing, usually this is something that we see in a higher frequency on girls with Turner syndrome, cardiovascular problems and ovarian problems. Now, one important aspect here in terms of exclusion of the diagnosis of Turner syndrome is girls who only have missing parts of the Q arm, the long arm, they don't necessarily have all the other features associated with Turner syndrome. And one of the recommendations in the latest guidelines, this may change, is that they're actually not diagnosed with Turner syndrome because the only problem that we'll have eventually is just ovarian failure with early menopause and sometimes difficulty getting pregnant. I mentioned some of the other associations that were listed there. Isochromosomes often are associated with an increased risk of autoimmunity, like what we see in Hashimoto thyroiditis or hypothyroidism, like what we see with Graves' disease of hyperthyroidism, like an increased risk of diabetes mellitus type 1, celiac disease, vitiligo. They're all autoimmune conditions, and girls who have isochromosomes, particularly the isochromosome Q, they have an increased risk of autoimmunity. And again, the more we're missing on the long arm, the higher the chances that there's going to be ovarian failure. And if there are more copies of the long arm, there's a lower chance of cardiovascular disease. It doesn't mean that you're not going to do your cardiac surveillance. It's important to do it, like I mentioned it, because then we don't know what is the proportion of cells who have that constitution in the heart or in the blood vessels. I mentioned briefly what is the aspect of the Y chromosome that eventually is responsible for the differentiation of the gonads and the change of the gonads into testicular tissue, and what explains, for instance, that an individual that is 46XY eventually has testicular tissue and eventually produces a hormone that gets rid of the uterus. Well, is that gene in the close to the tip of the short arm of the Y chromosome that is called the SRY. Is one of the genes that is responsible for the appearance of the testicular tissue. There are many, many other ones, but actually the very first one that has to do with that particular aspect is the SRY. And there is another important region on the Y chromosome that is the GBY, that is apparently the region where there is if that region is present, there is an increased risk of developing tumors of the gonads or the ovaries, the germ cell tumors or the gonadoblastoma. So the presence of that region in the genetic material that a girl has with Y increases the risk of developing those tumors. And this is the reason why right now, based on the current guidelines, if there is Y chromosome material, and it's not necessarily the presence of SRY, but the presence of this region between the SRY and the central aspect of the chromosome, the BY, is because there is an increased risk of gonadoblastoma. And that's why the recommendation is removal of those gonads for those girls. That recommendation may change eventually, as we know. Right now, the risk of somebody that has Y chromosome material to develop gonadoblastoma is somewhere between 4 to 60%. It's probably more towards 20%, 10-20%. But it's important to know that right now that is the recommendation. And if the gonads are not removed, then there has to be a plan for surveillance of those gonads as much as possible. The issue is that there is newer information that when these girls are followed long term, they do have a risk for gonadoblastoma, certainly, but it's possible that those girls go into puberty on their own, and it's possible that they also eventually are fertile, or that we're able to retrieve viable eggs from their ovaries, and so they offer some degree of fertility with artificial fertility at some point. So that's one of the aspects to look in the newer guidelines in terms of timing for removal of surgical removal of those gonads at some point. But again, I want to be very clear that the recommendation, the way it is right now, is removal of the gonads if Y chromosome material is identified. So these are one of the key points here. Again, Turner syndrome is a genetic condition, but it's not an hereditary condition. The absence of the sex chromosome eventually is a developmental process that happens in girls with Turner syndrome very early during their development. The diagnosis of somebody with Turner syndrome is a combination of information, the chromosomes, the physical findings that they have, and the structure of the chromosomes to conclude on that, and other aspects in terms of the examination, the presence of the pelvic uterus on the pelvic ultrasound. The presence of the different cell types and the structurally different chromosomes explains the variability, but sometimes it's very hard to assess that. And occasionally, the presence of specific chromosomes will hint us again on what medical aspects we need to be more careful with the patients. And the last point is how underdiagnosed Turner syndrome still is, despite NIPT, despite early surveillance. Unfortunately, this is a condition that we don't have newborn screening for yet. There are many strategies that are being developed to increase the diagnosis, but underdiagnosis is still a problem, and the average age of diagnosis is around 13 years of age, which is too late because we could do a lot of things for them before that age in terms of growth, in terms of conversations about future fertility, in terms of cardiac surveillance. And I wanted to finish with this one. So who wants to try to answer this one? The two possible options are in the bottom. We can leave it open so people can look. Yeah. Anybody wants to go over that one? Anybody? Let's see. And we're going to meet after this in Tanglewood's room to answer any questions. We have a Q&A session after that. Oh, okay, good. We have the answers there. But I don't see any. All right. So again, this is just to touch base. Can I go back to the original slide? So again, traditionally, we sort of thought about this way, and this way, and this way. Now we know a little bit more, and that's why the clinical judgment is so important, is that we could see this certainly, and this is not a condition that, this is not a situation where we face Turner syndrome. We see similar clinical findings, and we should do similar surveillance. But again, for this particular case, there was differentiation. For this particular case, for instance, there are other conditions where there is differences in sexual development that not necessarily will follow the medical surveillance of the diagnosis of Turner syndrome. And with that, I wanted to thank you again for the invitation and for your attention. And it's a pleasure for me to be here. We're going to be in the other room with a Q&A session. Thank you again.